Welcome back to McTox Curriculum. Our topic today will be on organophosphates and carbamates. By the end of this video, learners should be able to recognize the cholinergic toxidrome and understand the pathophysiology of cholinergic toxicity. You should be able to discuss initial management for an organophosphate or carbamate exposure. Starting with a case, we have a 54-year-old male farmer presenting with severe shortness of breath and an altered mental status. On initial exam, he has a decreased level of consciousness, and his vital signs show an elevated heart rate, rest rate, and a decreased O2 sat. Further information from the EMS crew reveals that he had a history of nausea, vomiting, and diarrhea prior to presentation. They also tell you that his house smelled faintly like garlic. His wife thinks some sort of chemical might have spilled on him earlier today. Upon completing the physical exam, you find he has pinpoint pupils, wet skin, a wheezy chest, and is passing copious liquid stool. After your history and focus physical exam, putting all this information together gives you a man with a chemical exposure on his farm that smells like garlic and has given him wet skin, a wheezy chest, altered LOC, vomiting, and diarrhea. Your differential diagnosis is pretty short at this point and contains only cholinergic toxicity. Let's refresh our memory about the muscarinic cholinergic symptoms. These are nicely summarized with the dumbbells mnemonic. Pay special attention to the killer Bs, bronchospasm, bronchorrhea, and bradycardia that can be deadly for these patients. There are two main chemical groups that can result in a cholinergic toxidrome. These are organophosphates, which comprise most of the pesticides and nerve agents, and carbamates, which contain all of the cholinergic medications, as well as some of the pesticides. Organophosphates and carbamates inhibit acetylcholinesterase, which is the enzyme responsible for degrading acetylcholine in the synaptic clefts. This causes increased acetylcholine at the target receptors and prolonged stimulation. To understand how cholinergic toxicity presents, we need to recall the structure of our nervous system and its receptor types. Nicotinic acetylcholine receptors are found in both sympathetic and parasympathetic preganglionic areas, which explains the presence of some sympathetic and some parasympathetic responses. Nicotinic receptors are also found in skeletal muscles, which leads to muscle fasciculation. Muscarinic receptors, however, are only found in the parasympathetic postganglionic area, which corresponds to many of our internal target organs. One of the most important points in treating a cholinergic toxic patient is to make sure that you, your staff, and other patients in the hospital are safe and not at risk of contamination by the affected patient. This means decontamination should be considered and undertaken prior to any other measures. This may include activated charcoal for an oral ingestion, or exposing the patient and washing them with soap and water for skin contamination. All of this must happen while wearing the appropriate personal protective equipment. While the specific antidote is being administered, the patient should receive ongoing supportive care for airway protection, hypotension, and hypoventilation. The life-saving antidote for these patients is atropine, which is an anti-muscarinic medication. A large amount of atropine may be needed to save one patient with cholinergic toxicity. It's advisable to use a concentrated form of atropine whenever possible, given the larger doses required. Atropine should be given as an IV bolus every 3 to 5 minutes, doubling the dose each time. The endpoint is a chest clear from secretions. It should be noted that atropine reverses only the peripheral muscarinic effect, not the nicotinic effects of cholinergic toxins. Pralidoxime is the second antidote for cholinergic toxicity. It helps prevent the permanent attachment of the organophosphate onto acetylcholinesterase. This regenerates the enzyme's activity. Pralidoxime is useful with organophosphates only and not carbamate compounds, as they do not form permanent bonds to acetylcholinesterase. Our final questions are 1. Why does pralidoxime have limited use in carbamate exposures? And 2. What lab tests can confirm organophosphate toxicity?